Good morning, welcome to In the Trenches. This morning's topic is going to be hyperthyroidism. Recognizing hyperthyroidism, sometimes it's easy, sometimes it's not as easy, but what you have to look at here, you have increased beta receptor activity and decreased alpha receptor activity. And you have catecholamine symptoms and protein-related symptoms. So the classic catecholamine-related symptoms: increased heart rate, increased pulse pressure. You can see lid lag, diaphoresis. The protein manifestations are more subtle. These could be a myopathy, kidney stones, hypercalcemia, change in mental status. Sometimes older people do not manifest catecholamine manifestations of hyperthyroidism, and that is what's known as apathetic hyperthyroidism. The next thing I want to comment on is the difference between hyperthyroidism and thyrotoxicosis. Thyrotoxicosis is the effect of excess thyroid hormone in the body. And hyperthyroidism is when the excess thyroid hormone comes from the thyroid gland, and it's usually due to Graves' disease. So let's go over the causes of hyperthyroidism. So you have somebody who's hyperthyroid, and you make the diagnosis, and you're going to get the diagnosis via thyroid function test. You're going to have a low TSH, and usually the T4 is elevated and the T3 is elevated. And you want to find out the etiology. So, number one cause is autoimmune, you have Graves' disease. Then you can have toxic multinodular goiter, that's called Plummer's disease. You can have a toxic adenoma. You can have iodine-induced hyperthyroidism, which is called iod-basal. You could have the thyroiditis or thyroiditis, where you could have subacute thyroiditis, postpartum thyroiditis, postpartum thyroiditis, lymphocytic thyroiditis. Something that exists on the spectrum of Graves' disease is something that's called hashitoxicosis. Then you could have thyroiditis factitia, where the patient's taking thyroid hormone. And then unusual things like TSH secreting adenoma, molar pregnancy. And there are medications that cause hyperthyroidism, but it's usually it could be either via iod-beta. You could have medication induced, like amiodarone. And you could also see this with tyrosine kinase inhibitors and with checkpoint inhibitors. So you make the diagnosis of hyperthyroidism. You want to examine the thyroid. Often you'll get an ultrasound. Graves' disease is the most common cause. And normally you break these into two categories. Okay, what we used to do, we used to get an I-123 scan. And if there was increased uptake would be Graves' disease, toxic multinodular goiter, an adenoma would have a certain type picture, TMG would have a certain picture, Graves' disease and so diffuse uptake. And then if you had decreased uptake, you had the thyroiditis. Okay, either that or you had thyroiditis factitia. These were the two major categories. Normally what's done now, you're going to get TSH receptor antibodies, including thyroid stimulating immunoglobulin. And if this is the case, and if these are positive, then you basically have the diagnosis of Graves' disease. At times to do a thyroid scan or at least an ultrasound. Now, if you do an ultrasound Doppler, it could help with Graves' disease. There's a pattern on it known as thyroid inferno, where you see increased vascularity. Plummer's disease or TMG, kind of you see in older people, but Graves' disease you can see at any age. The toxic adenoma is going to have a specific appearance. Now, Yod-Vasudal, okay, Yod means iodine in German, and in Europe, Graves' disease is called Basudal's disease. So this is iodine-induced thyrotoxicosis. This could be someone with underlying thyroid disease who's given radiocontrast dye, which may have iodine in it, or they're taking excess iodine. Often these people have underlying goiters, and it causes them to become hyperthyroid, the excess iodine. That requires a careful history. The thyroiditis, so subacute thyroiditis is known as De-Quervain's disease. It's a viral infection, and often the thyroid is very tender when you feel them, and their sed rate is very high. Postpartum thyroiditis is a similar situation with subacute thyroiditis. If you did biopsy the thyroid, which is rarely done, you would see granulomas. Postpartum is an inflammatory thyroiditis that occurs after a pregnant woman delivers a child, and this has an association with type 1 diabetes. Okay, and lymphocytic thyroiditis is kind of a non-specific garden variety. Normally when you have immune destruction of the thyroid, it's lymphocytic. There's a subset of Hashimoto's. Normally with Hashimoto's thyroiditis, that causes hypothyroidism. And whether a patient will get Hashimoto's or Graves depends on a certain HLA type that they have. But there's a subset of patients with Hashimoto's where you actually get hyperthyroidism. Thyroiditis fictitia, you have to be a good detective to pick this up. Classically, what you would see low uptake on the scan, and often what they would do with this is get a serum thyroglobulin. Okay, and this is in the thyroid gland, and if you have a thyroiditis, it would be elevated, or it would be low with thyroiditis factitia. But that's something that you can see. TSH secreting adenomas in a molar pregnancy, the idea is HCD binds to the TSH receptor. This is getting, or struma ovari, this is getting very esoteric. I want to leave that out. Amiodarone could cause hyperthyroidism two ways, and this is a commonly used med. Type 1 is iodine-induced hyperthyroidism, and type 2, you have a thyroiditis. Okay, so they're treated differently, but type 1 is iodine, thyroid hormone produced by the thyroid gland, and type 2 is the thyroid, it is leaking out thyroid hormone. It should be noted with the thyroidities, the hyperthyroidism is self-limited, and often these people could get hypothyroid afterwards, and then they become euthyroid, and a certain percentage of them will remain hypothyroid. So you want to make the diagnosis. Number one cause is Graves' disease, but you have to rule out these other things, and then you want to treat these people. And the other thing I didn't mention is AFib, and you can, that's on the differential. Any patient with atrial fibrillation, you need to make sure they're not hyperthyroid. Okay, so once again, it's understanding physiology, and obviously, ruling out a thyroid storm. This is not based on your labs. So someone could have a sky-high T4, but clinically is when you make the decision of a thyroid storm. These patients usually are febrile. They usually have high fevers. And actually, in somebody coming in with fevers, this is something you have to think of, especially if there's a non-infectious etiology being considered. Acutely, normally you treat these people with beta blockers. Normally, you want to slow down the heart rate, and the body's in overdrive. Probably propranolol is the best one, Inderal, because it also decreases conversion T4 to T3. T3 is a little more potent than T4, okay? And then, not talking about thyroid storm, you have options, and the major options are medications, radioactive I-131, and surgery. The medications are methimazole and PTU. So how do they work? They actually work on organification. They work on thyroid hormone synthesis. So if somebody's thyrotoxic and having a thyroid storm, you give them PTU or methimazole, it will prevent further thyroid hormone production, but it won't work on what's there. And they work at the thyroid gland. They inhibit organification. Basically, in the thyroid gland, this is a thyroid gland, you have thyroglobulin, and it binds to iodine residues, and it either puts out T3 or T4. Okay? And it inhibits, okay, the thioureas are going to inhibit your organification. They're going to inhibit the enzyme thyroid peroxidase and prevent iodine from binding to thyroglobulin residues and producing thyroid hormones. Now, they may also, work on decreasing T4 to T3 conversion, and they may have other mechanisms, some anti-inflammatory activity, but the major work is they inhibit organification. The one that's used the most is methimazole. Okay, PTU used to be used more. You can't give PTU in the first, PTU is used in thyroid storm, and you can't give methimazole in the first trimester of pregnancy because there's problems with scalp formation in the fetus. But PTU has been associated with hepatitis, and the risk is high enough, and it could also be associated with an ankylosing. Methimazole is less side effects. So the major side effect you worry about is neutropenia. And you can see this, and it often presents as a sore throat. And if you have a thyroid person who's on methimazole, tapazole, or PTU, and they have a sore throat, you have to get a stat. You have to get a stat CBC. And the other complication are liver chemistries. And these are used. I-131 will ablate the thyroid. And a lot of patients, it's just easier to ablate the thyroid, make them hypothyroid, and replace that. It's a lot easier to treat hypothyroidism. If somebody's very sick, you're going to get them euthyroid with medications and then talk about I-131 treatment. After that, you're going to have to hold, obviously, you're going to have to hold the thyroid medicines for a good week because they'll, inhibit the iodine from going into the thyroid gland. Surgery is not commonly done. Once in a while, it's done. And that's for Graves' disease. Toxic moldy nodular goiter is often treated with I-131, sometimes antithyroid drugs. And the thyroidities are usually treated self-limited. If they're having pain, fever, they're going to maybe be placed on non-steroidals that they could take them, and you're going to have these people in beta blockers, and you just follow them clinically. Beware of amiodarone. You have to monitor people. That's the big drug that causes this. But some of these newer agents used in oncology, like the tyrosine kinase inhibitors, and the checkpoint inhibitors are also associated with this, and you've got to be on the lookout for it. And I think with this, I'm going to stop. We're in the trenches.